The first of these, which is panic disorder. Now, panic disorder is characterized by panic attacks, which are discrete periods of intense apprehension, terror, and fear, often accompanied by a sense of impending doom. With panic disorder, an individual is susceptible to these attacks, and during the panic attack, they may experience several different physical symptoms, including chest pain, choking or smothering sensations, dizziness or faintness, hot and cold flashes, or trembling, shaking, or feelings of unsteadiness. The onset of a panic attack is often abrupt and usually reaches its peak in about 10 minutes. Now, the first panic attack is usually spontaneous. However, later on, certain situations which are similar to when the first panic attack occurred may cause more panic attacks to occur. These situations increase the likelihood an individual will have an attack because it's similar to the first situation in which they had a panic attack. An individual may recognize that their fear of having an attack is excessive, but they can't stop the fear and often experiences anxiety about having another attack in between the panic attacks. Next, we're going to talk about phobias, which are the most common anxiety disorders. These are persistent, unreasonable fears of a specific object, situation, or public place, which are coupled with a compelling desire to avoid the object, situation, or place. Now, phobias about specific situations or objects, such as snakes, spiders, closed spaces, or heights, rarely seriously interfere with an individual's life because they can simply avoid the object or situation. However, another type of phobia, social phobia, can be much more debilitating. In social phobia, the individual fears and avoids situations in which he or she could be watched by others, such as eating a meal in a restaurant or public speaking. Now, the most disabling phobia is agoraphobia. Agoraphobia is anxiety about being in a place or situation from which escape might be difficult or embarrassing, or in which help may not be available in the event of a panic attack or panic-like symptoms. Such places are often avoided, or they may be endured, but with great distress. Individuals with this disorder may avoid being on the street, being in restaurants, or being in stores. In some individuals, they may become so disabled by their agoraphobia that they refuse to leave their home. Next, we're going to talk about post-traumatic stress disorder. We often hear the term post-traumatic stress disorder, or PTSD, associated with war. Now, while war veterans can experience PTSD, anyone who experiences a severe traumatic event can develop symptoms of post-traumatic stress disorder. Now, post-traumatic stress disorder is caused by exposure to a trauma that involves actual or threatened death or serious injury, such as a plane crash, fire, or earthquake, or being molested as a child. The severity of the disorder tends to increase if the trauma was unexpected. Of course, one example of PTSD trauma is the events of September 11th that we are all quite familiar with. Many individuals experienced anxiety symptoms following these events, but some individuals experienced symptoms that were consistent with a post-traumatic stress disorder. These symptoms include a re-experiencing of the trauma through dreams and flashbacks, sleep disturbances, excessive alertness or a sharpened startle reaction, for instance, dropping to the ground when a car backfires. They experience anxiety, depression, or irritability, and avoidance of the stimuli associated with the trauma. Now, PTSD sufferers will often try to avoid situations that are similar to the ones in which they experienced the trauma. If they are exposed to events that are similar, they may find themselves experiencing some anxiety symptoms. For instance, if someone was involved in a traumatic hurricane or tornado, they may find themselves becoming particularly anxious and fearful during a bad storm where there are winds or high rains. The next anxiety disorder we're going to talk about is obsessive compulsive disorder. The essential behaviors of obsessive compulsive disorder, also known as OCD, are recurrent obsessions and compulsions. They're time-consuming and significantly interfere with the person's life. Obsessions are recurrent, persistent thoughts, ideas, images, or impulses that invade the person's consciousness and are senseless. They may also sometimes be violent or aggressive. For example, recurrent thoughts of drowning the baby during bath time. Compulsions are repetitive, seemingly purposeful behaviors that are performed in a nonsensical fashion. For example, compulsive hand washing until the individual rubs the skin of the hands raw, or compulsive checking routines, such as making sure the door is locked 20 times before going to bed. Now, some compulsions can last for hours. A layperson's way of differentiating between obsessions and compulsions are that obsessions are something that you think, while compulsions are something that you do. Now, anxiety disorders can be treated with psychotherapy and anti-anxiety medication. As I mentioned before, some antidepressant medications are also being used to treat anxiety. If you look at page 9 in your participant guide, you'll see the anti-anxiety medications listed, and they include some mild tranquilizers such as Valium, Ativan, and Xanax. In general, we can say the following about anti-anxiety medications. They usually reduce anxiety immediately. They also show, because they have immediate relief, patients readily take their medication, and usually there are few instances of non-compliance. However, these medications can be addictive. Because many of these medications can be addictive, there's a strong potential for abuse. Many physicians, particularly those who are not psychiatrists, may not monitor these medications closely enough for signs of abuse. If you have a defendant or offender who is taking these medications, you will want to monitor them closely, and if the individual also has a history of substance abuse or dependence, you'll want to make sure that the doctor is aware of that history so they can use some of the non-addictive medications if possible. Now we're going to turn our attention to Axis 2, which includes the personality disorders and mental retardation. Now first we're going to talk about the personality disorders. If you remember, personality disorders include traits that are pervasive, persistent, and inflexible. They can cause impaired functioning, they're recognizable in adolescence, and they impact all aspects of life. The personality disorders are categorized into 3 different clusters called Cluster A, B, and C. In our criminal justice system, we don't see very many of the Cluster A or Cluster C personality disorders. We tend to see most of the Cluster B personality disorders, which can include antisocial personality disorder and borderline personality disorder. Now, before we talk about the specific personality disorders, a word of caution. Many of the negative personality traits associated with the personality disorders, including those in Cluster B, can be found in the individual population in general. Probation and pretrial services officers often bear the brunt of these negative personality traits because of people's stress of being involved in the criminal justice system. However, you need to be very careful not to label someone with having a personality disorder when in fact all they have are negative personality traits. We all have personality traits, some of which are negative, and there's a difference between having a negative personality trait and having an Axis 2 personality disorder. Personality disorders are generally recognizable in adolescence and continue throughout the adult life, impacting all aspects of the individual's life and how he or she interacts with the environment. So, in order to determine whether somebody has a personality trait that is negative versus a personality disorder, there are a couple things that you can look at. One is the person's life history. Was there evidence that the personality traits occurred in childhood or adolescent, or is this a recent or isolated episode because of their current stress level? Next is the individual's relationships to determine whether these traits show up in other situations, such as with family, friends, or coworkers, or whether it only occurs when they're interacting with you, their officer. After you've determined that someone has a personality disorder, we need to look at the different types of personality disorders, the first being the Cluster A. Cluster A personality disorders tend to seem the most bizarre and eccentric to lay people. Individuals with Cluster A disorders can make plans and organize thoughts, but their thinking is illogical. In general, individuals with Cluster A disorders are not psychotic, but they can become briefly psychotic under stress or when abusing substances. The Cluster A disorders include paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. Now, paranoid personality disorder is characterized by a pervasive distrust of others. People with this disorder assume that others are always trying to exploit, harm, or deceive them. Because they assume others will try to use information against them, they're reluctant to form relationships and will carefully scrutinize everyone for evidence of disloyalty. Now, sometimes people confuse schizophrenia with the next two disorders, schizoid personality disorder and schizotypal personality disorder. So let's take a look at these. The first is schizoid personality disorder. This is characterized by a lifelong pattern of social withdrawal and a restricted range of emotion. Individuals with this disorder basically don't like being around other people. They're not antisocial, they're just asocial. People with this disorder tend to gravitate to solitary jobs or evening employment that involves little or no contact with other people. Now, a layperson would describe someone with schizoid personality disorder as being a loner or hermit, distant, solitary, and unsociable. For example, the individual who lives alone with their pets, works at night, and is reluctant to come to the probation office because they don't like being around people. Now, individuals with schizotypal personality disorder also have limited social relationships, but they exhibit disordered thinking and communication as well. These individuals, they have the limited social relationships, disordered thinking, and odd beliefs or magical thinking. A layperson might describe this person as being weird or peculiar. They often appear eccentric, dress outlandishly, and talk to themselves. They often have odd beliefs such as superstitions and beliefs in clairvoyance or telepathy. Now, an individual with schizotypal personality disorder might believe they have some sort of special powers of thought or insight, but they fall short of the criteria for a diagnosis of schizophrenia. These individuals may be involved in cults, strange religious practices, or other bizarre groups. Next are the cluster B personality disorders, which are the ones you're most likely to see in the criminal justice system. That's because these individuals tend to be impulsive, manipulative, and self-centered. Cluster B disorders include antisocial personality disorder, borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. Antisocial personality disorder is characterized by an inability to conform to social norms and continuous and chronic behavior that violates the rights of others. This disorder is more prevalent in men. A diagnosis of antisocial personality disorder can only be made after age 18, and it must include evidence of antisocial conduct prior to the age of 15. Now, some of the typical antisocial conduct you might see in someone prior to age 15 include lying, truancy, stealing, and substance abuse. Behavior typical of adults with antisocial personality disorder include inconsistent job performance, promiscuity, stealing, drunk driving, and spouse or child abuse. Those with antisocial personality disorder also tend to have a history of impulsive behavior, including substance abuse, which can get them in trouble with the law. Now, a diagnosis of antisocial personality disorder may prove to be a risk for future violent and aggressive behavior if that person has a history of violent behavior. Some individuals with antisocial personality disorder can be very charming. However, you must remember that these individuals are manipulative and cannot be trusted to carry out any task. Because these individuals often lack remorse for their actions, many people consider them as having no conscience. It's interesting to note that individuals with antisocial personality disorder often do very well in structured settings, such as a residential treatment program or a prison. They learn the structure of the system and they learn how to play the game. However, when returned to the community, they'll more likely than not return to their antisocial ways. Next, we're going to talk about borderline personality disorder. Borderline personality disorder is more prevalent in women and is characterized by a pervasive pattern of unstable relationships, self-image, and mood. Mood swings are quite common, and individuals can be seen as being argumentative and aggressive at one moment while they're depressed at another. Females with this disorder tend to be seductive and have a hard time maintaining appropriate boundaries. Almost all of their interpersonal relationships are unstable and intense. Glenn Close's character in the movie Fatal Attraction is an example of a borderline personality disorder. Individuals with borderline personality disorder are very dependent and fear abandonment. They're quick to anger, cannot tolerate being alone, and tend to idealize all or alternatively devalue those they have relationships with. Now this is known as splitting, judging someone as all good or all bad, and in all likelihood, you will be the target of this at some point if you're supervising an individual with borderline personality disorder. You'll find that they love you one minute and hate you the next. You may also find that this individual is often in a period of extreme crisis regarding their finances, relationships, health, and other areas. They're unpredictable and impulsive, particularly in activities that are self-damaging, such as extravagant shopping sprees or promiscuity. Now, one of the diagnostic criteria for borderline personality disorder is intense, inappropriate anger or difficulty controlling their anger. Now, a diagnosis of borderline personality disorder does not in and of itself suggest violent or aggressive behavior towards others. However, it does suggest violent or aggressive behavior towards oneself, and the impulsivity and anger may at times result in violent acts towards others. Violence towards another person will most likely be the result of the person with borderline personality disorder seeing themselves as being rejected by the other person. Now, in severe cases, individuals with borderline personality disorder may also show suicidal gestures or other self-mutilating behavior, such as slashing their wrists. They may show these gestures in an attempt to show their anger or to manipulate other people. However, suicidal gestures should never be discounted because 8 to 10% of individuals with borderline personality disorder do successfully commit suicide. Next, we're going to talk about histrionic personality disorder. In general, histrionic personality disorder is more common in women. Individuals with this disorder tend to overreact and are excessively emotional. They're very dramatic, exaggerate, and make everything sound more important than it is. These individuals sometimes appear to be in crisis because they're so flamboyant and excessive in their emotions. They're often sensation seekers who may get in trouble with the law, abuse drugs, or act promiscuously. Next, we'll talk about narcissistic personality disorder. The major characteristics of narcissistic personality disorder include a grandiose sense of self-importance. These individuals are preoccupied with success, power, beauty, ideal love, and a chronic envy of those who they perceive as being more successful. They often have constant attempts to get compliments and attention because they have a fragile self-esteem. They handle criticism very poorly and may become enraged at those who offer criticism. Now, those with narcissistic personality disorder can be exasperating to work with, because they are the know-it-all. They know more about the criminal justice system than you, the attorney, or the judge. Power struggles are also not uncommon with these individuals. They need to feel superior and they'll expect special treatment. For example, they may refuse to wait for an appointment, or they may refuse to reschedule so that they're home during a home visit. Now, the last of the Axis 2 personality disorders are the Cluster C personality disorders. These personality disorders are individuals who seek relationships and love, but don't have the social and psychological skills to establish or maintain relationships. The Cluster C personality disorders include avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder. Now, hypersensitivity to rejection is the central feature of avoidant personality disorder. Individuals with this disorder crave companionship, yet they avoid forming relationships because they fear rejection and need constant guarantees of uncritical acceptance. They also view themselves as being socially inept and unappealing. Individuals with dependent personality disorder exhibit a submissive, dependent pattern of behavior in order to gain acceptance and support. They allow others to assume responsibility for major areas of their life, and they do not like being alone for more than a brief period of time. Now, you can describe individuals with dependent personality disorder as having a severe inferiority complex. They lack self-confidence, they may speak in a derogatory manner about themselves, they are afraid to speak up in public, and they have difficulty they avoid relationships and have difficulty making decisions. Dependent personality disorder is more common in women, and these women may often find themselves in abusive relationships. Now, the last personality disorder we're going to discuss is obsessive compulsive personality disorder. Individuals with obsessive compulsive personality disorder display a pervasive preoccupation with perfectionism and inflexibility. This disorder is more prevalent in men and is characterized by orderliness, stubbornness, indecisiveness, and difficulty in delegating to others. Now, obsessive compulsive personality disorder does differ from the obsessive compulsive axis 1 disorder we discussed earlier. Where the axis 1 disorder is involved with the obsessions and compulsions, obsessive compulsive personality disorder is involved in more perfectionism. Think of the father who autocratically rules his his family. He's cold and unemotional. He degrades his children despite the fact that they make good grades, and he considers his wife, who's organized and efficient, sloppy and lazy. No one can live up to the expectations and perfectionism of the individual with obsessive compulsive personality disorder. Now, the last thing we're going to discuss today is co-occurring disorders. Co-occurring disorders are cases in which a substance abuse or dependence diagnosis exists along with another axis 1 disorder. If you'll turn to page 22 in your participant guide, you'll see more information about co-occurring disorders. Now, professionals have begun using the term co-occurring disorder versus the term dual diagnosis that we mentioned earlier because individuals often have more than 2 diagnoses in these cases. Co-occurring disorders have become the norm rather than the exception for many people, especially those involved in the criminal justice system. Some common co-occurring disorders include major depressive disorder and alcohol abuse, or antisocial personality disorder and cocaine dependence. Now, because individuals with co-occurring disorders have multiple diagnoses, they often have high rates of hospitalization, violent and criminal behavior, suicidal behavior, non-compliance with treatment, and housing instability. Researchers and medical professionals have debated about whether substance abuse causes the mental illness or mental illness causes the substance abuse in individuals with co-occurring disorders. Now, you may find some individuals who have a mental illness such as major depressive disorder who self-medicate with alcohol. You may also find individuals who abuse substances such as cocaine and develop other mental health symptoms as a result. For our purposes, it's probably not that important to know which came first. And regardless of which came first, it's important to treat both disorders at the same time. Unfortunately, there are still professionals out there who don't subscribe to this belief. For instance, there are some psychiatrists who may refuse to give medication to an individual with depression while they're continuing to drink. Alternatively, there are still some substance abuse treatment programs that insist that an individual not have any drugs, including psychiatric medications. What's most important for you is to find a treatment program that is capable of handling both disorders appropriately. If it's not possible to find such a treatment program, it will be important for you to refer for both the substance abuse problem and the other mental illness, and then for you to help coordinate treatment between the two and ensure that all treatment professionals are talking amongst themselves. Now, this brings us to the close of today's session, which was our introduction to the field of mental illness. During this session, we described how the Diagnostic and Statistical Manual of Mental Disorders is used by mental health professionals. We also talked about the differences between Axis 1 and Axis 2 disorders. We identified the basic characteristics and behaviors associated with key disorders. And we described some basic treatment for the mental health disorders. Now, I'm sure you all are overwhelmed a bit by all this information and that you'll need more time to learn more about all of these issues. If you turn to page 53 in your participant guide, you'll see some resources to learn more about all of these areas. In the remaining 2 programs of this training program, we'll discuss mental health disorders in the context of your job. Next week, we're going to discuss techniques for interviewing and identifying individuals with mental health disorders. Our focus during the 3rd program will be on locating and working with treatment providers and managing some of the special issues that occur with individuals with mental health disorders, including how to respond to suicidal or homicidal thoughts, or how to respond if an individual is having a psychotic episode. Thank you for joining us today. Now I'll turn it back over to Bob.
Thanks, Melissa. Thank you very much for a very informative session, and thanks for all your good work in helping us get the program developed. We have about 3 minutes left in the broadcast, so perhaps we can address quickly a couple of questions that have come in. One for you, Melissa, comes from Melanie Bedford from the Pretrial Services Office in Brooklyn. And Melanie would like to know what happens when symptoms of Axis 1 and Axis 2 mental health disorders are left untreated.
Excellent question, Melanie. You can think of the Axis 1 disorders as you would of any other chronic disease such as diabetes or high blood pressure. If they go untreated, they're most likely going to get worse. Now, there are some instances where different diagnoses will remit on their own, but for many of the diagnoses, active treatment is needed. Now, for the Axis 2 disorders, they're a little bit more complicated because, as I mentioned, they're harder to treat in the first place. We look more at management of symptoms a lot of times when looking at the Axis 2 disorders, so that will address certain things that pose a risk for you, such as the anger or impulsivity in some of the personality disorders, to ensure that we follow these folks appropriately.
Okay, Melissa, thank you very much. And in this minute we have left, Miggy, let me ask you one question from also the Pretrial Services Office in Brooklyn, which is, what is it we're expected to know about mental health as officers? Are we expected to be experts?
No, Bob. Officers are not expected to be experts. In fact, what I often tell officers is that the more familiar they are with resources in the community and where to find the information, such as the DSM-4, and know the differences between the medications and what they're used for, the better position they'll be in. But no, we don't expect them to be experts. We need for them to know where to get the information.
Okay. All right. Thank you very much, Maggie. We do have several other questions, and we will post the answers to those questions on the our website that is identified on page 53 in your participant guide. So that's it for us for this time around. We look forward to seeing you here next Thursday at 1:30, at which time Mark Embler and Tom Larson will be talking with us about how to identify and interview people who may have the potential for having mental disorders. And again, I would like to thank Melissa and Miggy for their participation in this broadcast and their good work in helping us get it all together. I'd like to thank you for your time and participation, and we look forward to seeing you here again next week, same time. See you then.